So we are having an exam at the end of the week next week, so we've got to get a lot of material covered. So this chapter will be done this week, and we'll be starting on renal at the end of this week. So respiratory system. We have a structural and functional organization to our respiratory system. Structurally, we have the upper respiratory tract where we get upper respiratory infections, and then we have the lower respiratory tract where we get lower respiratory infections. The upper respiratory tract is considered the nose, the nasal cavity, the paranasal sinuses, and your pharynx. The lower respiratory tract is then everything below that. So that's the larynx, the trachea, the bronchial tree. And when I talk about the bronchial tree, I'm talking about main stem bronchi, secondary bronchi, tertiary bronchi, and all of those areas that actually go out into the bronchioles, including the area that's called the respiratory zone. Respiratory zone is very special because that's where actual gas exchange occurs. So that's talking about respiratory bronchioles, alveolar ducts, alveolar sacs, and alveoli in that respiratory zone. Functionally, let's go ahead and take a look at the picture functionally. Conducting zone, this is all about moving air. Respiratory zone is all about gas exchange. So, conducting zone, moving air. No gas exchange in the conducting zone. So that's nose, pharynx, larynx, trachea, and bronchial tree. Minus the respiratory zone where gas exchange actually occurs. And in order to figure out whether or not it is a member of the respiratory zone, as long as there is a single alveolus attached to the structure, it's considered a respiratory zone. And so the conducting zone ends in a terminal bronchiole, and the respiratory zone begins with a respiratory bronchiole, and then alveolar ducts, alveolar sacs, and alveoli. Going into a little bit of detail on our conducting zone structures, the nose is there to actually help moisturize, which is humidify, warm, and filter the air. It also serves as a resonating chamber for sound production. That's not a conducting zone feature, but that's what it does. And it houses our olfactory receptors. Structurally, the first things that we encounter for air to move in is the nostrils. Then it goes into the nasal cavity, which is divided into two sections by the nasal septum, which is both bone and cartilaginous. And what kind of cartilage is the nasal septum made out of? Hyaline cartilage. It should be almost like a reflex for you guys. The roof of the nasal cavity is where we find the ethmoid bone. Remember, that's where our respiratory epithelium is, going through all the cribriform plate. And then the floor of the nasal cavity is, for the most part, the hard palate. Anteriorly, the bulk of the hard palate is our maxillary bone, and posteriorly we actually have some palatine bones, but they actually make up only a small portion of the hard palate. Mucosa-wise, it is ciliated simple columnar epithelium, but it's not just simple columnar, it is pseudostratified, which is still simple columnar epithelium, correct? Pseudostratified means it looks stratified, but it's not. So indeed, ciliated columnar epithelium, a simple columnar epithelium, of which pseudostratified is still considered a simple columnar epithelium. We have also in the mucosa lots of goblets that secrete mucus. which is helpful as it's nice in trapping particles. And the movement of the mucus is going to be dependent upon which way the cilia are going to beat. And so this is a ciliated epithelium. And which way do the cilia beat? Do they beat anteriorly, posteriorly, superiorly, inferiorly? Which way? If you beat superiorly, you're going for your ethmoid bone, right? Where's it going to go from there? To your brain? No. So posteriorly. And so the only time it gets overwhelmed is whenever you have an upper respiratory tract infection, correct? There's a lot of inflammation, a lot of mucus production, and then it comes out both directions. It comes out anteriorly and posteriorly. But for the most part, our mucus actually is going in a posterior direction. It's going to go down your throat, and that's another reason why you swallow. It's not just for saliva, it's also to actually help bring that mucus down to the esophagus. We have some structures that are called concha that are designed to increase surface area. And vortex the air. Vortex means tumble on around and stir it on up. And that's important because in order to actually get to our olfactory epithelium, we need to actually have some vortexing. Also, the more you vortex the air, the better able you are to moisturize it and warm it and filter it. So that helps to do that also for us. The pharynx is posterior structure. It has a nasopharynx, oropharynx, and laryngopharynx. Our notes say it connects the mouth to the larynx and the esophagus. So it is an area where things are going to go, and then things are going to actually be decided in a very specific area at the laryngopharynx, which direction we're actually going to take things. Let's take a look at the nasopharynx and the structures located in that. It comes up every single time. Structures associated with the nasopharynx. Remember, it's continuous with the nasal cavity posteriorly. We find in here the pharyngeal tonsils as well as the auditory tube. Remember, we call those pharyngeal tonsils also adenoids. The auditory tube has another name. We call it the eustachian tube sometimes, and the pharyngotympanic tube. The oropharynx, that is continuous with the oral cavity posteriorly. And we have two types of tonsillar tissue here. We actually have our pharyngeal tonsil, palatine tonsils and lingual tonsils. And then we come down to that structure called the laryngopharynx. And so it's kind of like the top part of the larynx. What we'll have here is a decision. Air to trachea and food to esophagus. And so this is the area where we're going to make a decision at the laryngopharynx whether we're going to open up, keep the airway open to the larynx for air in there, or whether we're going to close it off and let food go into the esophagus. So which one has the right of way? Of these two, air and food, which has right of way? And do you remember what right-of-way is? When you come to a stop sign, everybody comes to the stop sign. Who has the right-of-way? The person to your right. Okay, so that means that everybody has to stop for that one person to the right. So, who has to stop? Air or food? Air has to stop for food, and so food has the right-of-way. So food is the answer. Air can go into your stomach, yes? And all it does to you is make you burp. But when food goes into the airway, you start coughing. And also when you swallow, do you still breathe when you swallow? No, because if you still breathe when you swallow, indeed, you'll initiate the cough reflex because some of that food will go in there. So food actually does have the right of way. The larynx is also referred to as the voice box. Our notes here reinforce switch box for air and food, also the area of sound production. And structurally, it is made up of a series of 9 cartilages. 3 are singular, and then we have the rest paired. And anteriorly, all you can really appreciate is the cricoid cartilage. A lot of people have a hard time saying that word, cricoid. Can you say cricoid? Cricoid. And then we have the thyroid cartilage. Thyroid cartilage is the largest portion, the largest cartilage that we actually have of the larynx, and both of those are singular. What's important to realize is as you take a look at the posterior side, because here's our anterior view of the cricoid, very narrow little guy. Posteriorly, he's actually quite big on the posterior side. On the anterior side, we have a lot of thyroid cartilage obvious, but on the posterior side for us, take a look, it stops. The thyroid cartilage is discontinuous posteriorly. On the cat, it still actually has some continuation with that structure. We have the hyoid bone, and we have some various membranes or ligaments, because a ligament is an attachment of bone to bone, correct? And we can also say the same thing for bone to cartilage or cartilage to cartilage. However, they call them membrane in one area and ligament in another area. Go figure, ligament or membrane actually works fine for me. So thyrohyoid membrane is between the hyoid bone and the thyroid cartilage, and then we have the cricothyroid membrane in this area, which is really important because this is the area that if you had to do an emergency intubation of somebody, that is the membrane or ligament that you would actually pierce. So it's important that you realize when you find your larynx, go ahead and find your larynx for a moment, and do a little swallow for me real quick, and see if your larynx moves. It moves superiorly. And that's an important feature because the superior movement is actually what tips the epiglottis over the opening, which is called the glottic opening. Epiglottis, above glottis. So epiglottis tips over the glottic opening when you bring your larynx superiorly. So it's a kind of a teeter-totter type of maneuver. So that's an important thing. But if you are encountering somebody that has an airway obstruction that's above the larynx, you can go right underneath the laryngeal prominence. You can feel for the laryngeal prominence, and you just go right down to a little divot in there, which is the cricothyroid membrane or ligament. And you can take a knife, even a pocket knife, and you can cut right over that skin, right over that little divot, into that little area, make a hole, and then put your little MacGyver breathing tube in. So that is an important anatomical structure because when you are straight in the midline in that area, you will not actually be cutting any major blood vessels or having any major bleeding or any of that type of stuff. So it's important to realize that that laryngeal prominence or Adam's apple is a very important landmark because then you go south of that, and when you feel the little inward, that's where you want to go if you were to actually have to do an emergency tracheotomy. Now, what type of cartilage is the larynx made up of? Hyaline cartilage, except for one thing. The epiglottis is made out of elastic cartilage, one of the few elastic cartilage structures in our body besides our ear. So we see the epiglottis peeking up anteriorly, but it's easier to see it from a posterior aspect. And remember, that's the guy that closes off the glottic opening, which is going into the larynx and into our airways. And so that upward maneuver when you swallow, which is food to go into or saliva to go into your esophagus, that maneuver is ensuring that that closure occurs and that that food does indeed go into the esophagus. The arytenoid cartilages are important as that they actually are at the posterior aspect of the vocal folds, the true vocal folds. The cuneiform and corniculate cartilages are structures that you don't need to identify on your cat, but they are paired, they're very small and are associated with our voice box. Thyroid cartilage, indeed, remember, laryngeal prominence or Adam's apple for that. Epiglottis covers glottic opening. When you swallow. Larynx pulled superiorly. When you swallow, and epiglottis tips, literally tips over and covers. Covers glottis. So glottis is the formal name for the glottic opening. This then will divert, flow into the esophagus. If non-air material into glottis, this will initiate cough reflex. So it is a reflexive action, a cough reflex. So anything, any little particles, any little this, we're going to cough and we're going to do our best to force it out of the airways because only air is supposed to go in the airways. Let me ask you about this when you're unconscious. What do you know about the cough reflex when you're unconscious? It's not there, and so when somebody is unconscious, what is it that you're supposed to do? Yeah, you're supposed to try and, no, that's, if they're unconscious, I didn't say obstructed, I said unconscious. If they're unconscious, you turn them on their side because you're trying to actually ensure that whatever secretions that are in the mouth or any vomit or anything like that doesn't go into the airway. So only works when conscious. So our vocal ligaments, also known as our vocal cords, are actually elastic connective tissue, and they're on either side of the larynx and are responsible for sound production. We have some false vocal cords just above. And this is the same also in the cat. So when you first look in, what you think are the vocal cords or folds are false. So what you first see is wrong because the other guys are down a little bit deeper in that. The other thing too about the false vocal cords, they are not elastic CT and not involved in sound production. They're just a structural support because the true vocal cords below that are actually slightly dependent upon their structural support that they provide. Sabrina, would you mind closing that door for us? I greatly appreciate that. Trachea is the windpipe. Ears going in here after we've decided at the area of the larynx that that's the direction we want material to go. The trachea has many layers to it, and as we go on down, we'll still find these layers evident as we go down the bronchial tree. But let's start with the luminal side of things. So on the luminal side, which is the inside of that, we find mucosa. And then we'll have a submucosa, then we'll find cartilaginous rings, and finally on the exterior we'll find adventitia, which is unusual because typically on organs suspended in a cavity you have serosa. So our trachea and our esophagus, neither one actually have a serosal surface, they have an adventitial surface. That is a lot of loose CT with blood vessels in it, and one of the things about adventitial surfaces that they actually are not very good at containing things. And so a lot of times when we get cancers of the trachea or esophagus, because of the adventitia, it's easy for them to actually go ahead and start spreading along that plane. That little serosal surface or saran wrap is actually pretty protective overall. Looking at the notes here, it says mucosa, ciliated, pseudostratified, columnar epithelium with goblet cells. And then submucosa has seromucous glands, so serous watery fluid as well as mucus fluid, and they are what actually produce the bulk of the mucus. Our submucosal glands will do that. And then we have our tracheal cartilages as we move on down. They are actually C-shaped rings of hyaline cartilage with the open portion of the C posteriorly. It's not directed anteriorly, it's directed posteriorly. And then the adventitia is the outermost, relatively tough CT layer, but unfortunately allows for spread of cancers. Now, it's important that you realize that the C-shaped rings, so they're not real rings, they're almost rings, are connected posteriorly by a muscle called the trachealis muscle. What kind of muscle would this be? Smooth muscle. So this is a muscle that's not under voluntary control, it's under involuntary control. The other thing too, that the cartilage rings is connected to one another by elastic connective tissue. I left a little room off the side because I want to make a little drawing of like a tracheal cartilage here. So let's make a little C-shaped guy here. And let's go ahead and put a trachealis muscle back here. And then behind that, let's go ahead and put our esophagus back here. And one of the things that's important for you to realize about the esophagus, it is ordinarily collapsed. And as you are dissecting your cats, what little bit of work you guys did, you should have noticed the esophagus was very flat. And indeed, that's collapsed. It's very flat. The only time it's not flat is when something's going through it. And so when a wad of food, which we call a bolus of food, goes down the esophagus, what's really interesting is when you swallow, the only thing you guys noted when you swallowed was that your larynx moved up, right? Well, bolus of food, theoretically going down, should be pushing your trachea forward, correct? It's really interesting it doesn't do that. What it does is, as this bolus of food, one more. As this bolus of food is going down our esophagus, our trachealis muscle does this. It relaxes. Another reason why food has the right of way. Food is obstructing the airway. You guys follow me on this? So food is obstructing the airway. Our trachealis muscle relaxes, allows that bolus of food to go down. So in front of the bolus of food, the trachealis muscle relaxes. And after the bolus of food goes down, the trachealis muscle contracts and then allows for the lumen of the trachea to become patent for airflow to actually occur again. It's kind of a pretty unique way of actually taking care of business there for you. At least I think it's kind of cool. Let's go on down now, down the trachea, and go to the area called the bronchial tree and the various subdivisions. So our trachea will terminate actually at our sternal notch. Find your sternal notch on your chest. Find your sternum, and then there's this bump that protrudes outward. That's called your sternal notch. That's where your second rib actually comes in, and that is right behind that where the trachea actually branches or bifurcates. So that's where your right and left primary bronchi actually start, right underneath that area right there. So sternal angle, I hope I did I say sternal notch or did I say sternal angle? Notch. Notch is up above. Go down to the angle. Sorry, guys. I go, wait a second, I think I said the wrong thing. So notch is up above, and angle is the bump that's protruding out. So that's where we actually have our right and left primary bronchus or main bronchus to come off. What's important is the right main bronchus is more vertical than the left. And this means if you aspirate, you know where it's most likely to go. Important in aspiration of a foreign body. Because most of the time when you aspirate something, you're in an upright position, and so then it's going to actually lodge into the right primary bronchus or main bronchus. Looking up here at our bronchial tree, of course, trachea. This is our primary bronchus, and also called main bronchi. Then our secondary bronchi are actually colored in blue coloration. So wherever we get a split and have a tendency to get a slightly smaller lumen, that would be considered the next level or the secondary for that. And then we see our segmental or tertiary bronchi. So it's important that you know primary is main, secondary is lobar, and tertiary is segmental bronchi. And as we continue to go down, we get smaller and smaller in our branching. So theoretically, you have quaternary and other names. But as long as we have cartilage in the walls, it is a bronchus. It becomes a bronchiole when there is no cartilage in the wall. So the only thing keeping the lumen patent at that level is actually smooth muscle. Again, we're into our trachea here, and then we see our primary bronchus, and then we see the secondary here, and then off of that secondary, we'll end up with our tertiaries coming off. Going on down, the cartilaginous rings, which are actually more circumferential, not just C rings in the trachea, when they're on the primary bronchus, are going to be replaced with plates of cartilage as we are descending into the lung. Going deeper into lung tissue. The epithelium, which was columnar, is going to get shorter and shorter. Eventually will become cuboidal, and then eventually will become squamous. So as we go in deeper into the lung tissue, columnar, cuboidal, and then squamous. Of course, as we get shorter and squatter, we'll lose our cilia as well as our goblet cells. And as we go deeper and deeper into the lung tissue, what's important is the smooth muscle will actually increase as percentage of the wall of the structure as we go deeper into the tissue, because that is what is important in keeping the lumen patent. So arterial, it should sound like arterial, bronchial, arterial, and that's just a smooth muscle structure. So only thing keeping lumen patent or open. So those are all our conducting zone structures that we were talking about. Terminal bronchial is the end of the conducting zone structure. And whenever we have respiratory bronchioles, that means an alveolus is actually hanging off of it. And that means that we have gas exchange actually occurring in that area. Respiratory zone structures, again, reiterating respiratory bronchioles, alveolar ducts, alveolar sacs, and alveoli. The alveolus, the little balloon, is where actual gas exchange occurs. Taking a look at the histology. The reason this is called a respiratory bronchiole is there's stuff that's actually part of the wall. So a respiratory bronchiole still has some mucosa that has some structure to it and even some smooth muscles. So we have some thickness there. But once you get into alveoli, which is just basically the little sacs here, they're all over the place, you will find alveolar ducts, which look like a track through the alveoli. And then if you find a collection of alveolar sacs, that's how you identify that. And then the alveolus itself is just a little balloon in the midst of all of this. So we have a lot of balloon-like material or squishiness to our lungs. The other thing that's important for you guys to take a look at the cartoon here trying to show you the balloon with a hairnet over it, so to speak. So those are the capillaries that are over that. So the balloon is much more larger surface area on the inside than the capillary network that's going over it. And so there is this big area to actually harvest or do gas exchange from. For that little bitty capillary, big area, big ocean of air, so to speak, to actually go ahead and equilibrate the gases that we need to exchange. And remember, we're going to use the same process that we've used in other areas, simple diffusion, going from an area of high concentration to an area of low concentration. And that's going to be the process in our capillary bed. Respiratory membrane is defined as the wall of the alveolus, which is simple squamous epithelium, plus the basement membrane between that and the next area, the nearby capillary, which is also simple squamous epithelium that we also call endothelium because it's a vascular structure. Our next cartoon down here shows the respiratory membrane a little bit more in detail over here off to the right. But let's take a look at the alveolar construction itself. Big balloon area, if you're a little macrophage, a huge balloon that you're actually living in, with some connections, some pores between one another, because this is a big ocean of air exchange that's actually occurring in these guys. And we have inside that, we'll have our little, let me erase my circle here. See these little guys here, here. Nice big simple squamous epithelial cells. We call those type 1 cells. Make up most of the alveolar wall, at least close to 90% of that alveolar wall. And then we have a type 2 cell, and it's more or less cuboidal. It's not very cuboidal, but so these are type 1s. This guy here is a type 2 cell. He's got some processes coming off of him, but you can see cytoplasm. In any cell that you can see a little bit of cytoplasm, it's more of a cuboidal cell. That cell is important because it secretes a material called surfactant. And surfactant, we're going to talk about in a little bit, is completely responsible for keeping these little wet sacs from collapsing. Because one of the things that you know, whenever you breathe out, is it just air that you're breathing out? Is it just oxygen and carbon dioxide that you're breathing out? There's moisture. And so if there's moisture that you're breathing out, that means inside these little sacs is water. There's moisture. And let me ask you, I want you to think about these alveolus just like a little balloon. And if you blow up if you have a wet balloon on the inside and you're not blowing it up continuously, what does that balloon want to do? Collapse and stick together. And so surfactant is actually the chemical that keeps it from collapsing and sticking together when you're not continuously trying to blow them up. There is also a little cell called alveolar macrophages running around in our alveoli, and they have a cute little name associated with them. They're called dust cells. We have no cilia in this area because by the time our air gets to this area, it should have all the nasty stuff should have been removed from it, but that is not always the case. And so we have those little macrophages in there taking care of carbon particles that may have actually got in there if you're a smoker and things along that line, or if you have an infection. These guys are there to help to eradicate bacteria and things along that line. Capillary, indeed, simple squamous epithelium, also known as endothelium, and blood is flowing very, very close to the air because the only other separation is the type 1 cells on the other side and the basement membrane. We're going into just some basic gross anatomy here when we talk about lungs and pleural coverings. So pleural always means pulmonary or lung tissue. So lungs and pleural coverings. We have a right lung and we have a left lung. The right lung has 3 lobes and the left lung has 2 lobes and is actually smaller in size than the right. And part of it is because it has a cardiac notch. Which also decreases some of the volume for that area. Each one is suspended in their own pleural cavity and they do not interact with one another. So if you have a problem on one side, the other side does not experience that problem. If you had a pneumothorax, which is air in the thoracic cavity on the right, the left will not feel it, other than we'll actually have some shifting because we're supposed to have equal pressures on either side. If you have pneumonia on the right, the left will not experience pneumonia on the right unless we have pus dripping over to the other side or getting in there, bacteria getting in there from the bloodstream and things along that line. So they, right and left, do not really communicate with each other than via the main stem bronchi going to the trachea itself. Our lungs, the lobes themselves are divided into bronchopulmonary segments by connective tissue, and each is served by its own artery and vein. So as you follow the airway out, there's typically an artery laying on one side of the airway and a vein laying on the other side of the airway. We call our pleura, the serosal lining is called pleura, and we have a parietal which lines the cavity in which the lungs are suspended, and then over the surface of the lungs is a visceral layer. And so it is actually intact, and so we don't have any leaking or bleeding of air that's in the lung into the cavity itself. In between the visceral and parietal layers is the pleural cavity full of pleural fluid. And is it really full? Do you think there's a lot of pleural fluid there? There's enough pleural fluid to decrease friction and to provide the friction and cushioning, but also pleural fluid enough to decrease friction and to provide tension for lung contact with cavity. With lung visceral contact with parietal layer. This is important because we're going to take 2 saran wraps and we're going to put water between them, and what are they going to do? They're going to stick to one another, and this is important in actually keeping our lungs expanded or inflated. Which comes to our next topic of breathing, which is also called ventilation. So respiration is gas exchange, ventilation is the movement of air or breathing. Inspiration, air is flowing into the lungs, which is also when we inhale. And expiration is gases are leaving the lungs, which is also an exhale or exhalation type of process. I didn't bring the little bell, but in lab, your lab instructors will show you this lung bell. That's a glass bell that has a stopper in it, that has glass tubing in it, that has a Y in it, and then attached to the tubing Ys are two little balloons inside this glass bell. The bottom of the glass bell is open except for some blue nitrile gloves, and it's acting as a pseudo or faux diaphragm. Okay. Because it's important that you realize how air actually gets into the lungs and how air actually gets out of the lungs. It is very different than what you probably think of conceptually. Let's go through a little bit of the pressure talk here, and then we'll go into our diagrams down below. Atmospheric pressure, that is at sea level, that's 760 millimeters of mercury. Now, let's talk about intrapulmonary pressure, which is pressure within the alveoli, also known as intra-alveolar pressure. So intrapulmonary, inside the lungs, also inside the alveolar pressure, alveoli. And then intrapleural pressure, pressure that's actually inside the pleural cavity, which has that pleural fluid and the sticky sides to one another. And this is almost always 4 millimeters of mercury less than intrapulmonary pressure. So if a pressure is less in one area than another area, it's almost acting like a suction to that wall. So it's what keeps, a very important part of keeping our lungs inflated. Number 2 here, the thoracic pressure relationship diagram. Let's look at this and go into intrapulmonary and intrapleural pressure and inflation. So all around us is the atmosphere, correct? And so all around us is at 760 millimeters of mercury of atmospheric pressure. This is due to gases in our atmosphere, correct? So there's, when we're out in a vacuum, that means there's no gases. So right here, there's gases all around us, and they're exerting their effect on us, and it's 760 millimeters of mercury. Well, what's the pressure inside your nasal cavity? 760 millimeters of mercury. What about your pharynx? 760 millimeters of mercury. What about your trachea? 760 millimeters of mercury. All the way down. Are you guys following me? That 760 millimeters of mercury, if you're not doing anything, if you're just at kind of at ambient rest, as long as there is a connection, the pressure, the gas pressure is the same through everything that's interconnected, all the way down to the alveoli. So when you're not doing anything, when you're just in a stasis kind of situation, all the way at the alveolus, the gas pressure is 760 millimeters of mercury. Now, inside the cavity where the lungs are sitting, we have 756 millimeters of mercury. And it's important for you to realize the lungs are elastic tissue, so nice and stretchy for you. And we have more pressure inside our balloons than we have outside our balloons. So what do our balloons want to do? They want to expand to fit the cavity. Are you guys following me with this? Pressure wants to go from high to low, just like concentrations of materials in solution. air goes from high pressure to low pressure. The cavity itself is a lower pressure than what's inside the lungs, and so it keeps the lungs pushed up against the wall of the cavity. That's a very important aspect of how our lungs stay inflated. There's more to this story, and we're going to get to that. Let's take a look at the little pistons here. And this is important that you understand the inverse relationship of volume and pressure. So we have an inverse relationship of volume what are you doing? To pressure. Our little diagram over here on the left side shows that we have some air molecules inside this closed chamber and a piston is on top of it. When we pull the piston up, we're increasing the volume, correct? In that chamber. What are we doing to the pressure in that chamber? Decreasing it, because now the concentration of those little molecules, we actually have more space around that. So that's a decreased pressure. And when we push down on the piston, we decrease the volume, but we increase the pressure. This is very important in how actually gases are moving in and out. Again, this is showing us how as long as everything is connected, the pressure in one area is going to be the same as the pressure in the other area as long as it's connected. And then if we increase the pressure in the area above our diaphragm, if we increase the volume in the area above our diaphragm, that causes a decrease in pressure and we will pull air in. So this area here is our environment. This area here is our lungs. So when our diaphragm contracts, it increases the volume, decreases the pressure, and we pull air in. The opposite is actually occurring over here on this side. When our diaphragm relaxes, we decrease the volume and increase the pressure, and so molecules move from high pressure to low, and we push our air out. That's an important aspect of actually how our gases move. We are literally creating a suction, decreasing the pressure, which is like suction, sucking air in, and then when we exhale, we are passively pushing air out. And that's not what most people actually think about in how you ventilate. Let's take a look at surface tension, elastic recoil, as well as pleural pressure as various factors which help us keep our lungs inflated, and also factors that are trying to actually work against us in keeping our lungs inflated. Surface tension holds the lungs to the thoracic wall because there are no CT connections. Between the parietal and visceral pleura. Instead, we have serous fluid between the two surfaces, causing increased surface tension, or so to speak, stickiness. You know, you have a glass and it's a little wet on the bottom and you put it on a coaster and then you go to pick up the glass and the coaster comes with you, correct? At least it does in my house. And you have to be careful that it doesn't eventually fall off because of the weight of the coaster. It depends upon the type of coaster that you actually have. And so this is what keeps our visceral and parietal surfaces stuck to one another, so to speak, but also that serous fluid helps to also minimize friction as we actually breathe. As far as elastic recoil goes, lungs indeed are full of elastic tissue that stretches, but recoil, elastic tissue, recoil is the springiness to actually go back to the non-stretched form. And so elastic recoil is working against our lungs to keep them inflated, because the lungs want to be like elastic tissue. You've stretched me, so now, if you're not continuously actively stretching me, I want to actually then go back to a smaller size. So this elastic recoil is trying to pull lung tissue away from inner wall. The other thing that's also important is if you've ever watched any sort of movies when they do coronary artery bypass surgery, they cut through the sternum. So they do a median sternotomy, which is cut through the sternum. And do you guys have any idea what happens after you take away the sternal connection between the ribs? Boing! They want to spring open. And so even the wall of our thoracic cavity wants to pull away from the lungs. The lungs want to pull away from the wall, and the wall wants to pull away from the lungs. And this is kind of working against keeping the lungs inflated. But this is also what helps the lungs to deflate as we ventilate, as we breathe air in, and then as we relax. This helps the relaxation, which is a passive process, for our lungs to actually empty of air. Pleural pressure, always less than atmospheric pressure. Remember, this is another word for intrapleural pressure. So you'll see we have a lot of shortcuts for some of the words that we're doing. So pleural pressure plus surface tension are working to keep the lungs expanded and are able to overcome elastic recoil. So the elastic recoil is working against the expansion, but surface tension and the negative intrapleural pressure, which is trying to suck the walls of the lungs against the wall of the cavity, is keeping our lungs nicely expanded. Inspiration, inhalation, again, diaphragm contracts, moves downward, and increases thoracic volume. If we increase volume, that means we decrease pressure, and we pull air in. And let's, I don't like the word pull. I'm going to use the word suction. We suck air in, because suction is a negative pressure thing. In addition to the diaphragm being the main organ responsible for inhalation, we also have some other muscles that help us, and those are the external intercostals, because they increase the anterior and posterior dimensions. Increase thoracic cavity volume. And you can put your hands around your chest and you can feel actually an lateral as well as anterior expansion of that thoracic cavity. So increased thoracic cavity volume, which means therefore, again, decreasing pressure and therefore sucking air in. So indeed, intrapulmonary pressure will decrease. And what's important for you to realize, as the lungs are suspended in this cavity, anything that the cavity experiences, the lungs will also experience in that aspect. So as we are pulling on the walls of the lungs, as we inhale, because we're pulling on the walls, that means that we're creating more space in the intraalveolar area, which means, again, more space intraalveolar area means air actually flows in. So that intrapulmonary pressure decreasing is going to be an important aspect of pulling air in. Exhalation or expiration is a passive process ordinarily. Muscles relax. And if you'll notice, exhalation takes more time than inspiration. Muscles relax passively. And you end up pushing air out because we will have a decrease in volume when this happens, and therefore an increase in pressure inside. And air will move out. We can actually forcefully make our thoracic cavity smaller by contracting our internal intercostals as well as our abdominal muscles. When we contract our internal intercostals, we actually pull our abdominals, we pull our rib cage downward. And decreasing volume of the thorax. Factors that will influence your ability to move air, which is what ventilation is all about. When you're hooked up to a ventilator, isn't that what a ventilator does? It literally is moving air. So remember, ventilator, ventilation, moving air. Lung compliance, lung elasticity, which is actually a little bit different, and then alveolar surface tension. So lung compliance, the ease with which you can actually blow up your lungs or expand your lungs. So you guys know various balloons that you've actually had to blow up. You know, they've never been blown up before. What do you think about the compliance of balloons that have never been blown up before to the compliance of balloons that have been blown up several times? Well, compliance is down, right, on the one that's never been blown up. So that's what it's actually talking about, lung compliance, how stretchy they really are. And so that's an important aspect of your ability to pull air in, correct? In order to bring that air in, that compliance is going to greatly affect that. What if you have scar tissue? That will have a negative impact on compliance, correct? I don't know if you've ever heard of pulmonary fibrosis, but what do you think fibrotic lungs are like? What do you think their compliance is like? That's really bad. So fibrosis will decrease. So all these that we're talking about here are going to decrease compliance. Scar tissue, fibrosis. What if you actually had an infection? What do you think that's going to do with your compliance? That will also decrease compliance. So there's a lot of ways to actually decrease compliance of your lungs. Lung elasticity, well, that's then we want to spring back into a small little wad of lung tissue itself. So that's the opposite of compliance for us. And I call this recoil. So if they're not very elastic, let's see, that makes it harder for us to get the air out if they're not very elastic. And a good example of losing your elasticity of your lung tissue is if we have a brown paper bag and I blow it up. It's easy to blow it up. It's very compliant. But then what about its ability to actually, empty out the air whenever we're not trying to actually actively fill it? That's something that's very common for people who have COPD or emphysema. So people with emphysema have lost their compliance or their ability for lung recoil. And they also have a problem with what are called air trapping. Most people with emphysema, their chests are kind of barrel-shaped because they've lost all that lovely pull against the spring, and so their chests get actually larger and larger in diameter. Alveolar surface tension. Water is inside our lungs, as I mentioned earlier. Water is polar. Polar things like to actually attract one another. Polar molecules do. And this is why we have this nice high surface tension because of water's polarity, why we even have actually a surface to our lakes and things like that. When you land on, when you're water skiing and you are going pretty fast and you land on, and you fall, and you hit the surface of the water, it has a definite solid feel to it for a moment of time. And that's because of the polarity. If we have high surface tension inside our little air balloons with a bunch of water, that means it's just like trying to blow up a wet balloon. That's all collapsed on its sides. Again, this is going to decrease compliance, right? It's going to stick together and we're going to have a hard time blowing it up. So high surface tension means that it creates difficulty in inflating your lungs because our alveoli are actually collapsed. And that's where those type 2 cells are so very important because they create surfactant. This is a lipo fatty protein that acts like a detergent in that it is designed to break surface tension. So if we have high surface tension, what this means when surfactant is present, we have low surface tension. And the way surfactant works is you have your little sac and you have your surfactant molecules on the inside. As long, and you have let's say a finite number of surfactant molecules, because this is what's important. And as you blow it up, the surfactant molecules get further and further apart. No big deal. But then as you are deflating or exhaling, then of course that little sac starts to collapse. And that's what is important about surfactant. The surfactant is like little opposite magnets. And as it collapses and the surfactant molecules get closer and closer to one another, they actually will repel one another. And they're trying to push and keep the airway open. So it's the concentration of surfactant that keeps your lungs from collapsing. Am I making any sense with that? So surfactant is the issue with premature babies. Because when a preemie is born, the type 2 cells have not matured enough to produce sufficient quantity of surfactant inside the little alveoli. And so because there's not enough that opposite polarity trying to push each other, or not opposite, but like polarity trying to push each other away from one another. And so those little air sacs will collapse because they're full of, they're full of amniotic fluid, because the baby has never had to breathe before until it's been born, because that's what the placenta does for the fetus in utero. And now it's out, its airways are not full of air, its airways are full of water. And so when it takes its first breath, it has to be a very important, big effort. because we have water in here, and now we're going to try and suck air into these water-filled channels. Once we get air into the water-filled channels, if we have enough surfactant, those little air-water areas now will not collapse, which means the next breath in will be able to blow it up more, and the next breath in will be able to blow it up more and more and more. And so that's actually how it happens. There are little airways. As with each breath, there's more little alveoli popping open, pop, 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 open as they actually breathe. And as long as there's surfactant, they'll stay open. But if there isn't enough surfactant, they collapse. And then what do you have to do to a preemie that has, quote, immature lungs? You put them on a ventilator to keep blowing up their balloons, right? And so you give them positive pressure ventilation. You're pushing air into them, trying to blow up their balloons, hoping that time will actually occur for the maturation of those type 2 cells to actually produce surfactant for them. So surfactant is a very important problem in preemies. In other words, not enough surfactant. But as long as you have enough of these lipoprotein molecules, when the airways start to collapse, it's just like, no, they start to push each other apart and keep the airways open or patent for you. What would happen if the surface of the lung got a hole in it? The actual surface of the lung got a hole in it. What would happen to that lung in that thoracic cavity in its own little pleural space? What would happen to it if the lung surface got a hole in it? The pressure then inside the cavity would be the same as the pressure out in the air, and the lung, because of its elastic recoil, would actually then collapse. And so that's a collapsed lung, right? That's one way you can get a pneumothorax. Most people are used to pneumothorax occurring in a different way. That's when somebody stabs you, and instead of the visceral pleura having a hole in it, it's the parietal pleura with a hole in it. So that space, it's really important that that space is isolated from our atmosphere. Because if we actually then connect it to our atmosphere, then the pressures are the same, and our surface tension will not be enough to overcome elastic recoil. You guys follow that? And so what they do, if for some reason you have a hole either on the surface of the lung or with the cavity, they always stick in a chest tube, correct? They stick in a tube into the chest between the ribs, and they do what? Push air in? Oh, they apply a vacuum. And that's another reason why I also use suction, because they literally suck the air out of the pleural cavity, and they keep sucking it out until whatever hole occurred with whatever surface seals off. And then once that hole seals off, they keep sucking out whatever air is in there until we get back to our proper pressure, which is -4 millimeters less, and then boom, the lung is filling up that cavity again. And then you pull out the chest tube, and because the way you put it in, the little layers will then actually cover up, and you don't have a hole where you have to worry about another hole that has to be corrected for that. Another question I want to ask you guys about: what if you try to hold your breath, squeeze your nose, close your mouth, and try to inhale? What would the pressures be like with that? So think about this. You close off your nose and your mouth, and you try to inhale. What are you doing to the pressure inside your pleural cavity and inside your lung tissue? Because you're creating a negative pressure, aren't you? You've got it all closed off, but you are now trying to increase the volume, which means you decrease the pressure. And as soon as you do that, as soon as you open up whatever blockage you have, air will flow on in. Well, let's now block our nose and our mouth and try to forcefully exhale. What are you doing to the pressures there? So we talked about it. You try to inhale, but you're blocked off. Pressures get negative around the lungs. We know it's negative, but in the lung tissue too, it became more negative, and as soon as you opened it up, everything flowed on in. Now let's do the opposite. Let's close everything off on the way out and then try to decrease the volume. The pressure inside the lung tissue itself, intraalveolar pressure, would get greater, correct? What about the pressure around the lungs? Would it get more negative? No, because also that volume is decreased, correct? So as long as we're decreasing the volume, whether it's inside the lung tissue, the alveoli, or around the lung tissue, that increases the pressure and we're pushing on the lungs. But do our lungs collapse if we do that maneuver? Does the pressure around the lungs get greater than the pressure inside the alveoli? No. And part of that is because we've got this air that we've trapped inside, correct? And so even though we're pushing on the lung tissue around it, it's still not going to be greater than the pressure inside the lung tissue itself, and so our lungs do not collapse. So these are some maneuvers to actually be aware of for exam purposes. Principles of gas exchange. We have a couple of people who obviously like physics. Dalton and Henry. This is all about gas laws. We'll just talk about Dalton and then we'll stop. Dalton's law. Total pressure in a mixture of gases equals the sum of the individual partial pressures. And partial pressure is defined as the pressure that an individual gas exerts if it's in a mixture of gases. What this is trying to tell you is how we measure gases. We measure gases by the pressure they exert on their container. That tells us if a gas has a higher partial pressure, that means we have more of that gas. If we have a lower partial pressure, that means we have less of that gas. And so partial pressures with Dalton are all about how we measure gas concentration. We have around us nitrogen gas. We have oxygen gas, we have carbon dioxide gas, and we have water in gaseous or vapor form. Around us at sea level, nitrogen is at 569 millimeters of mercury. Oxygen is at 104 millimeters of mercury. Carbon dioxide is at 40 millimeters of mercury. And interestingly, water vapor is at 47 millimeters of mercury. They all add up to 760 millimeters of mercury. So Dalton's law defines how we measure gases. Or their concentrations. So it's the pressure they exert on whatever space they're occupying. We'll stop there. We'll get into Henry's law because we have to know a little bit of physics as we talk about gas exchange.